body like they show in this picture, inflate it a bit, and then just pull it down. Don't be afraid to actually like inflate it because it needs to be bigger than the size of the object in order to pull it out nicely. So give that a try. All right, ear to foreign body. This can be a trickier one, right? Unless it's sitting right there, this can be a little bit anxiety provoking. So I tend to just look at both ears, go for the ear first that doesn't have anything in it, that makes the kid a lot more calmer. Because in all honesty, these kids show up to the ER and they've been like scolded on the way there that, oh, why did you put that in your ear? What, what are you thinking? And so they're already anxious. So if you go right to that ear that's the problem, I find it just increases anxiety. So just be like, hey, we're just gonna check your ears. I'm gonna look at the good one first, no big deal. And then kind of take a peek at what's going on with the other. Ideally, get the kid to sit comfortably. If it's on the parent's lap for them to hold them, that's totally cool. Try and retract the pin a little so you're almost pulling up and back, and that'll actually straighten out the canal for you, okay? There's a few different ways you can go here. You can do mechanical extraction using forceps. You can use irrigation and suction. The nature of the foreign body should ideally, again, tell you what you should be doing. If this is something soft and mushy, maybe you're not going to be able to get it out like good by grabbing it. Maybe you want to flush it. If it's something round and hard, like a bead, that can be a little tricky as well with the forceps. So if the other thing is, if it's something that we think might be alive, like a bug, ideally you want to kill that thing first. And you can use mineral oil. People use viscous lidocaine, and that should kill it first. Kind of gross, but it happens. You see it all the time.
Have you ever tried the Dermabond on the Q-tip for like a...
I personally haven't. I saw a lot of videos on it. I know Jeff Brallo has done it a few times. I think it's a great idea. If it's something hard that you think may work, yeah, to take a swab and to take a few drops of Dermabond and actually stick it to the object. If it's something you just can't grip. And then you just hold on to it for a little bit, let the Dermabond dry, and then maybe you can pull it out. I don't know. Yeah, like I guess it depends on the surface of the object.
Yeah, that tends to stick a little better if it's like not a totally smooth surface. If it's like a pencil or eraser or something, yeah. Rather than a smooth round bead, it tends to stick a little bit better. But it's definitely worth a shot, especially if it's very superficial. You can kind of see it, but you just can't get a good grasp on it. Absolutely.
Wait, can we talk about that for a second?
Sure.
You mean you put the Dermabond on the end of the instrument?
Yeah, you put a good drop on the end of the Q-tip, and then you stick it to the object. Ideally, you don't want to like stick it to the canal. So yeah, ideally you want to push your scissors up to get it to that. So this is an interesting little otoscope because you can like go through it. Our otoscopes, you can slide the lens to the side. It's not that optimal, but you can slide the lens to the side and actually go through the otoscope. But this is how you should kind of approach it, if you can. I tend to just get a really good look, kind of figure out where it is, drop the otoscope, and then like go in and grab it. But again, you don't want to go stabbing the canal or creating a laceration because it's then a nice bloody ear canal, and that's not going to be fun. So there's actually a great, it wouldn't load the video for me. One of my references is a New England Journal of Medicine article that if you just Google like forceps ear foreign body, there's a great video about how this woman goes in and shows you how to do all of these. It's pretty straightforward, but again, it's something just good to practice. Okay, so irrigation. How many of you guys have irrigated before? Yeah, it works pretty well most of the time, right? We tend to do it if there's like really thick cerumen and you want to try and get that out, but if there's a foreign body, you may be able to flush that out too, especially if it's like something a little softer that you can't get a grip on. This is really how you go about it. Use a syringe and a butterfly, and then you basically are going to cut to your desired length. I mean, you don't have to go too far, but this is actually nicer to use this than the angiocath, because the angiocath can actually be a little bit rough at the end. And it's sometimes a little too straight, whereas this gets nice and curved, and you can kind of curve it up into the canal. Make sure the water's not cold when you do this, okay? That won't be fun for them. And really get them, wrapped up, a few chucks, a few of those white absorbent towels that we have, and then a little kidney basin. And I just tell them actually, and I've had kids actually describe it to me like this, it sounds like farting in your ear, okay? Because it's the water going in and it's the bubbles, and I've had kids be like, oh, someone's farting in my ear. That's exactly what it sounds like, okay? So it's just bubbles, it's gonna feel warm, it's gonna feel wet. Again, just tell them how it's gonna feel. I would actually, what I tend to do is I let them see this little contraption that I've made, I let them touch it. I think kids have an inherent fear of needles, and sometimes they associate that with syringes, right? They're used to getting their vaccines all the time. So show them that this is not a needle that's sticking into their ear. It's nice, it's soft, it's like a little drinking straw, okay? Again, just using kid-friendly terms is going to be really helpful. All right, yes, sir. Sure.
I like that. I use it a lot, and it works very well. You just got to be careful with things that swell up with water.
Right.
Sometimes they may get actually more occluded, right? So, but otherwise, it's a very nice technique. And I use only the butterfly. I like embedded in the angio cap.
Absolutely, I agree. That's what I've been using since residency. It's pretty easy to manufacture yourself and just kind of go for it.
And you really can't cause damage with it unless you're a brute and go all the way in.
Right, yeah, you don't want to go too far. Exactly. The last thing is suction, which I don't think I've actually ever done this, but it's a great idea. So you want to use the smaller suction catheters. I don't actually know where to get those, but I'm assuming if you ask the nurse, we may be able to find some. But you basically want to, again, use the otoscope to help you see where the foreign body is. If you can see it, then move the lens to the side and kind of just slip the suction catheter in. If the suction will attach to the foreign body, again, it has to be, the foreign body can't be that big or heavy because it's not that strong of suction. But that's another option to try this if you can't get it out. Pretty non-invasive as well. Once you get the foreign body out of any of these orifices, always check them again because you want to know, did this create an abrasion? Is there like, hey, I got one tic tac out, is there another one behind it? You know, those are the kind of things where just because it's out doesn't mean you're done. So you should still be checking all these spots. Okay, here's our next one. We're gonna leave the ears and the noses. Here's your classic little 2-year-old. She was. Pardon me? Sure. Yeah.
Just keep in mind also this isn't an emergency unless there's something alive in their ear. So like when it comes to how far you're gonna go to do things, like there's nothing heroic about getting it out and causing a lot of damage. They can go to ENT tomorrow, they can go to ENT later that day to get it out. So like give a valiant effort because it's uncomfortable, but like don't go to heroic measures necessarily and risk a lot to the patient for it.
I definitely agree with the ears. The nose, it depends on what it is, because obviously you're going to ask for it, like, what issue. So I think AT will come to noses, you know, they definitely won't do ears. You know, you can't all on the But,
Those have better equipment in the clinic than we do. They have a microscope, they have a bunch of stuff that makes it much easier for them in clinic. So I would never force them to come to the ER. Sending a patient to the clinic is better for the patient too.
Absolutely. Okay, so this little girl, she's 2, and she just had arm pain. They were coming home from the park, and Dad was holding her hand, and all of a sudden she started crying. She really is refusing to use this left arm, and she's kind of holding it at her side. The nurse calls you in to triage and is like, hey, I'm going to send this kid for x-rays. Like, what do you want to order? So do you guys need to x-ray this kid?
No.
Right, so this is a purely clinical diagnosis of a nursemaid's elbow, right? Classic age group, classic kind of holding the arm at the side. A lot of times, this is just a radial head subluxation. It slips out from this ligament over here, the annular ligament. And it can be really uncomfortable. It's classically done when either a kid is either crossing the street or walking up the stairs. They kind of get pulled at the forearm, and it's usually an upward force, and that just kind of distracts. I've actually seen kids actually get this when they're crawling, newly crawling, and you know they're kind of rambunctious to crawl, and they've actually like just put a little too much force on it, and it slips out. That's another situation that I've seen. But this is like absolutely classic. Oh yeah, swing me while we're walking, and there you go, like pop right out. So this is a clinical diagnosis. You don't need x-rays unless you think there's a fracture somewhere else. So when you get a kid like this, they're in pain, get Motrin on board, right? Even before you even touch them, I would just get them something for pain because it's going to help you process in the long run. These are the kids that I actually I examine the good arm first, right? I'm gonna palpate your clavicle, shoulder, elbow, forearm, hand, wrist, all that good stuff on the good arm, so that they know that I'm not going in there and I'm gonna try and, hurt them. And then you can kind of just watch these kids, and a lot of times they're screaming in pain, so you may say, oh, I can't really appreciate if it's the clavicle or the shoulder. If it's classic like this, and there's really no other deformity that you're seeing, I think you can clinically go ahead and proceed as a nursemaid. And then if it's not reducing to your liking, then maybe we think of other things, okay? But this should, again, be a clinical diagnosis. A few different options. Pronation and supination. Again, first get the pain control on board, because I guarantee it'll help you. Pronation, I'm a fan of the pronation. A lot of people do supination. What you're gonna do is you're actually just gonna stabilize at the elbow. You're gonna rotate the hand into pronation, and you're gonna give it a little, what I consider like a little torque, a little downward motion. You should ideally feel, with the hand that you're stabilizing at the elbow, you should feel a little bit of a click. If you don't, it's not to say that it didn't work. I always just like give it some time. So I try maybe once. If I didn't hear the click, maybe I'll try again with a little bit more hyperpronation, and then kind of just leave the kid alone. Let the Motrin work, let the kid calm down, and then go and reassess. The other option is to do supination, which is something that was classically taught to me in residency, but I never really used it because I didn't have great luck with it. But it's basically you have them palm up and you just have them flex. I sometimes feel like it's just not enough. So I was kind of thinking, like, what's the deal? Is this gonna work? Is it not gonna work? So I found an article on it. You may feel the click, but I usually come back in about 15 minutes and this is what I see. Both hands up, using the iPad, they're swishing, they're playing Angry Birds, whatever it is, and they're good to go, okay? So the Motrin is kicked in, because remember, they did have some type of muscular trauma go on, so the Motrin is nice for the inflammation. And then you kind of just, the parents are like, oh my God, you fixed my kid in 5 minutes. So I looked at this article in Pediatrics from '98. They compared supination with flexion to hyperpronation. They had 90 patients. It was a clinical diagnosis of nursemaid, and they were either randomized to pronation or supination group. First attempt success rate, 95% in hyperpronation, while only 77% in supination. Only 2 patients in this hyperpronation group needed 2 attempts, versus about 10 kids in the supination group needing the second attempt. Conclusions were hyperpronation technique is requiring fewer attempts at reduction. It's more successful more often than supination, and it's also more successful if supination failed. So if you did supination first and then pronated, you have better luck. So I've always done hyperpronation. I'm not going to fault you, you can do either one you want. This data is showing us that hyperpronation is a little bit more successful. The key here though, if you've tried to reduce this a couple times, the kid is not going back to using the extremity. It's been like 15, 20 minutes. You've tried a few different maneuvers. That's the type of time to start thinking of other things. Is there a fracture in there that I'm missing? Something else going on? But for the most part, you have good luck, but it can happen. Questions on that? Yes?
More I actually do them both.
Okay.
If I think it's nursemaids, I'll go in there. The kid's gonna be pissed no matter what. I range it through hyperpronation and supination, and then just like you said, drop the mic, walk out of the room,
Exactly.
and go back in a couple minutes and see if it works.
Yeah.
That I recommend if you don't think there's any other trauma or fracture, but go. The highest utility is gonna be the first time you grab the kid's arm. He doesn't know what you're doing. After that, he's not going to trust.
Yeah, then you'll have a fighter on your hands, exactly.
I would just say press on the radio play while you're doing this. Because, I mean, we kind of talk all about supinating and pronating, but you just said that it's a relaxation. So just push it back in. I mean, obviously you can do this while you're having pronating or while you're supinating.
Which direction does it go, Walter? Anterior, posterior, medial, lateral? Which way do you push?
I push from the volar aspects to the posterior.
One more comment. You'll find that a lot of these kids will come in and the parents will be like, it's their wrist, it's their wrist. Because they just have this way that they hold their hand, or they, if it wasn't a witnessed thing, and they all hold their wrist for whatever reason. And the parents are like insistent, it's their wrist. And they'll just be like, oh yeah, maybe it's a little swollen and all this stuff. But eventually when you see enough of them, you'll see the way that they carry it, and they do mostly hold their wrist. But yeah, it's on their wrist.
And this is a great procedure for the interns to get to do, right? So if there's ever a kid like this, just don't let the fellow reduce it. Just say, I want to do it. I've never done a reduction, and we'll let you do it. We've done enough of them. Okay, another thing to talk about, urine catheterization, right? This is like, everyone's like, oh God, we gotta send the urine on the baby. So I'm gonna try and walk you through some little tips and tricks, because it's never that easy. But as long as you know like what you need to do and how you need to do it, at least you'll be a little more comfortable, okay? The big things that I found are positioning is key, and I'll talk a little bit more about that. Always having an extra set of hands, whether this is a nurse, a med student, fellow resident, whatever. Extra set of hands for the legs, because they always get in the way. You definitely want the parent involved. They're the one who's going to help kind of calm this child. This is a sterile procedure, so you really need to have everything that you think you're going to need at the ready. And my major tip, if you take one thing away from this, is actually to the urine cup that holds the culture, always have it ready and loosened, okay? Because I don't know how many times that I'm just like getting my gloves on, oh my God, they're peeing, just catch it, okay? It happened to me just the other night when I was working, and it was great. I like said a little prayer after. I was like, oh God, so it was great. It's even nicer if you've done it, if it happens after you've cleaned, okay? So, big things to talk about here. Preparing the patient and the family is one of the biggest parts. Any parent that you say you're gonna have to use a catheter into any type of the genital site, they kind of lose it. This is the time to use really nice language, okay, when we talk about it. I call it a small tube. It really is a small tube. You can show it to them. I think, mothers may associate a Foley when they were pregnant, like, oh yeah, they had to put the Foley in me and it probably was really uncomfortable. This is very small. It's a very quick procedure. We're just going in and we're coming out. This is not a prolonged procedure. It's not going to stay in there. It's not sharp. It's not permanent, and the whole thing is your baby may be uncomfortable for a short period of time while we're doing the procedure. It burns a little. They may cry. A lot of times they're crying, A, because we're holding them down, and B, just because, yes, it's not the most pleasant, but if we do it quickly and you help us, then we should be able to get it done fast and efficiently. Gathering your supplies, right? I'm going to go through a whole slide with that, so we'll talk about it a little more. Assessing the anatomy. So this is the time when you're examining this kid to kind of get in there before you even set up your supplies. Get in there, take a good look, okay? I always find boys are a lot easier than girls, but once you get accustomed to it, it can be just as easy. This is the time actually to like really get in there, grab the light, use the overhead light to your advantage, light things up. Get the parent to hold the legs back so you can see what you're getting at. We just had a kid the other night who had hyposmania, and we needed to get a urine on him. And when I looked at the new urethral opening, I was like, oh my God, I don't think they make catheters that tiny. Like, it was so incredibly small. This was a baby that thankfully peed for me. But it's the kind of thing where like you need to know that going in, so you're not like gloved and sterile, and you're like, okay, now let's take a look. That's going to be a little more challenging, okay? And then the parents are going to get annoyed that you didn't think of things. Holding properly and securely. This is ideally knees to the chest, okay? Have the baby lay down, have the parent at the head of the baby helping you hold the knees up, okay? And if they don't feel comfortable and they're not holding the baby tight enough, this is the time to get someone else to hold the knees up really tight to the chest so that everything's out of your way, your urine cup's not getting kicked over, the baby's not kicking into the sterile field, okay? Once you have all your stuff, this is literally like, I see the hole, I'm going for it, pull back for urine, and then you're out. You don't need that much urine, you don't need to be in there for that long. Repeated attempts of like, oh, I don't know if I'm in far enough, that's gonna cause trauma, that's when you're gonna get blood in the catheter, and then the parents see it, and then they flip out, okay? Go in, keep going, you're not gonna do too much damage if you just keep going. Eventually you'll stop, and then pull back and see if you have urine. And honestly, if you don't see any urine, the kid is tolerating the catheter okay. I have been known in the past to actually just like leave the catheter, put a tegaderm on the catheter itself, and kind of like put the diaper back on and just kind of leave it for a little bit. That's if the parents are willing to let you like kind of just chill with it for a bit. Because you could go back in 15 minutes after the baby's fed, pull back on the syringe, and you have urine. And then you didn't have to do a repeated attempt. So kind of keep that in the back of your mind that that is an option. But again, it's going to be a little situationally dependent. Clean up the patient. So after we've made this beautiful sterile field, get all that iodine off. It's actually very itchy when it dries. And a lot of times we're just quick to get them wrapped up and here, take your baby back. If you don't clean it off, it's still pretty uncomfortable, Okay, so use nice warm wipes or the gauze and just kind of give them a good wipe down. And then depending on the age of the patient, try and give them a reward. If it's a bigger kid, stickers, a lollipop, whatever you have. Babies, I just give them back to mom and I give them a big hug kind of thing. And it usually works well. All right, here's your urine cath supplies. This is basically everything you should be putting out, okay? I tend to do like a clean, dirty approach. Blue gloves for cleaning with the iodine, okay? Have someone to help you kind of get all this ready, but that would be like my dirty phase where I clean everything. Take those gloves off, put on my sterile gloves, and that's when I'm getting all my cath and all that stuff set up, okay? Always need Surgilube. You need a small syringe to collect your urine that you're going to attach to your catheter. Have some gauze at the ready. The urine tube, so you're not like futzing around, like where am I sending this, what am I doing? You have your tube ready to go. And this is the tube, the canister that I want. Always open up, have it on the side, the top is loose, ready to go. Because sometimes once you're cleaning the babies and you stimulate them, they may pee for you. And then you've got a clean catch and you're good to go, okay? Now what to do with your catheter size, okay? Everyone's like, I don't know what size to get. For the most part, your littler babies are gonna be like a 6 or an 8 French. And then as you get older, you're gonna move towards your 8 French. And of course, as you get a little older than that, 10, 12, 14, and whatnot. But for the most part, I would probably grab 2 sizes. I'd probably grab like a 6 and an 8 if I was doing a little baby. Because you never know, once you get in there, you may be like, this catheter's way too big, okay? So anatomy. In females, I really like to use the knee to chest approach for sure. And actually, as you do that, you tend to rotate them back a little more. And as you're passing, you really just have to look for 2 holes. You're looking for the urethra, which is going to be more superior, and then the vaginal opening is going to be a lot larger, okay? Once you have good lighting and you have their knees up, you can actually kind of slip the catheter